Hello, everyone. Thanks for joining us for this Part B General Practice Common Rejections and Denials webinar based on submitted claims, those claims submitted on the CMS 1500 claim form or the electronic claim, the 837P professional. My name is Mary Moko. I'm a specialist on the Provider Outreach and Education team at WPS Government Health Administrators, or WPS GHA. I will be your host today, and assisting me is my friend and colleague, Aline Sigler. Here is our disclaimer, and we do include this in all our education, and it really is simply to remind learners that we made every effort to provide current information that is correct, but the information is subject to change. It is on the CMS website where you will find Medicare rules that determine final coverage, and these rules, regulations, and other rulings will always prevail. We will provide responses to any questions based on the facts given. And just as a reminder, CMS prohibits recording of this presentation for profit-making purposes. So we do ask that you not take any screenshots or record this. Our agenda today reflects only those items that I will cover now during this education event. We ask that learners carefully read those advertisements on our website to reinforce the specific education that we plan to provide during our webinars. So topics that I advertise that I would cover today are specific to Part B, Specialty 01 providers. That's general practice. Those who submit claims on the CMS 1500 form or the 837P professional electronic claim. So during the next hour, I am going to talk about common rejections and denials for general practice providers or submitted claims, and how to fix or avoid both rejections and denials. And I'll also include during this presentation and on my slides various resources that will help you do just that, fix or avoid those common rejections and denials. If there's time at the end of our presentation today, I will answer questions live. Otherwise, I'll provide an opportunity for you to send in a question if we don't have time. So to fully understand rejections and denials, it's really important for everyone to recognize the path that a claim takes, or what we like to call the life of a claim. Here is a simplified graphic on how a claim gets into our system. So the provider would provide the service, submit the claim on that 837P electronic claim or the CMS 1500, and the system may reject the claims. And when that happens, this is a batch rejection, and when that rejection happens, a 277 or 990 report is generated. Now, most providers do submit claims electronically. Very, very few qualify for a waiver under a law that prohibits payment of services or supplies that a provider did not bill to Medicare electronically. To confirm claim receipt, providers should use the 999 report. Providers would use or their staff would use the 277 report that provides more specific information. And our electronic data interchange, or EDI staff, really provides some great information in the Medicare 276 and 277 companion guide. That's the name of it. This is a guide that they put together that helps clarify and further define data content requirements for electronic claims. And if you're looking at your handout here on the screen, you will see that I have included a link to that. So based on these reports, you will know if the batch is rejected and if you need to correct or resubmit the claims. Here then is a simplified graphic that shows what happens to a claim that Medicare deems as unprocessable. That's CMS's term. I have to laugh sometimes because when I'm typing things, it sometimes highlights and doesn't recognize as a word, but it's called unprocessable. And really what we're talking about here, folks, is a rejected claim. Rejected claims are very different than denied claims. So here's the simplified graphic. The provider would provide the service, submit that claim to Medicare, and because Medicare deems it as unprocessable, something's invalid, something's incorrect, something's missing, that claim is actually rejected. There is a remittance advice notice generated that tells the provider or his or her staff that the service was indeed rejected. I just mentioned to you that there is really a huge difference between rejection and denials. And a lot of people, and I catch myself at this sometimes, use one word over the other or instead of the other, and we use it incorrectly. So we really need to, and me included, remember that rejection is just that. It's unprocessable, it's rejected, and a denial is a claim that's adjudicated. So let's take a look at these differences here. For a rejected claim, and remember CMS calls those unprocessable, they're really just kind of booted out and returned on the front end. They're never really processed. These are missing or incorrect information on the claim. Something could be invalid, maybe something was transposed. But for these rejected claims, there are no appeal rights. You need to resubmit the service. For rejected claims or unprocessable claims, when you're looking at the remittance advice, you will see a remittance advice remark code, and I'll talk about those in just a minute, of MA130. This means that your claim is incomplete, it's invalid, and there are no appeal rights. What you need to do is fix it and resubmit it. For these claims, rejected claims or unprocessable claims, the patient is not liable. So you will see a CO16 group code on the remittance advice. That's a contractual obligation. It means that the provider cannot bill the patient. Remember, though, that you're going to fix it and resubmit it. Now, denials shown here on the right side of the claim are actually processed. They are adjudicated, and denials mean that the claim fails to meet payment criteria. This could be based on a law, what we call a statutory requirement. Perhaps it denied for medical necessity or frequency. Maybe it was eligibility, the reason why that claim denied. But for those claims that are denied, you will see the notice on the remittance advice of MA01. And that MA01 triggers a message on the remittance advice that says there are appeal rights. I should say, back up just for a moment, say most denied services will provide the right to an appeal. There's just very few exceptions where there is no right to an appeal. So for denied claims, then patient liability is determined. So let's take a look at that graphic then that shows the path for a processed claim. The provider provides the service, submits that 1500 claim form or the 837P, and then during the processing of that claim, there is a decision to pay the claim or deny the claim, or pay claim lines or deny claim lines, and then a remittance advice is generated. So I want to talk about that remittance advice, or the RA, just a little bit more. We do refer to this sometimes as the remittance notice versus the remittance advice. Sometimes we call it the RA, as I mentioned. Most providers receive an electronic remittance advice. This is an ERA, as opposed to a standard paper remittance, which is the SPR. Now, depending on how the claim processed, it may include information about any adjustments made to the claim or denials. It could also include information about something that's missing. Sometimes it even provides notice about refunds or offsets. The electronic remittance advice is going to provide payment information about the transfer of funds and payment processing from a health plan to a healthcare provider's bank, or the explanation of benefits or remittance advice. So CMS has prepared some information. They call it a guide to help understand the remittance advice. And this information is available on CMS's website. I'll have Aline actually place the link for that into the chat so that you have that information. This includes, if you look at this web page, an introduction to the remittance advice, components of it. It helps you read both an institutional and a professional remittance advice. And today I'm talking about professional remittance advices, those claims that are on the 1500 or those services that are submitted on that 1500 claim form or on the 837P electronic transaction. And it even includes even more information than the items that I've published here in this slide or on this slide and in your handout. Now, codes on the remittance advice are going to provide information about the claim or the claim lines. Claim adjustment reason codes, we call these CARC, C-A-R-C. These explain why a claim paid differently than it was billed. And your remittance advice remark codes, or RARCs, RARCs, provide more details about the adjustment that's described by the CARC, the CARC. Another type of code that appears on the remittance advice is a group code, and these convey the financial responsibility for any unpaid portion of a claim balance. So I talked about the CO earlier, contractual obligation. The provider is liable and can't bill the patient. A PR is patient responsibility. The patient is financially responsible for those services or charges for those services, any unpaid amounts. You can find code lists on the Washington Publishing Company's website. This is the contractor that maintains the codes for CMS, those codes that appear on that remittance advice. Now, we understand that some of those codes may be rather cryptic or may seem to be out of date. And by what I mean here is that some of the code messages may include an outdated acronym. I'll point those out later to you. Sometimes a code on the remittance advice for a rejected claim will say denied. So there again, you really need to keep straight in your mind and know that a rejected claim is very, very different from a denied claim. And sometimes those words are used interchangeably, and they really should not. But we have no control over those codes that appear on the remittance advice. It is the Washington Publishing Company that maintains those for CMS. Now, after reviewing your remittance advice, you will need to choose your action. So for an unprocessable or rejected claim, you're going to need to fix that error and resubmit the claim to Medicare. If the claim or the claim line denied, there could be multiple actions to choose from. You might be able to simply resubmit the service. You might be able to use a process called the clerical error reopening, or CER, to fix those clerical errors. And CMS defines clerical errors, this includes minor errors or omissions, as human or mechanical errors on the part of the party or the contractor. And I'll talk more about the CER process later in this webinar. Another action to consider is an appeal, and the remittance advice is going to provide those appeal rights. I'll discuss appeals a little bit more also later in this webinar. So those of you or those providers that are registered users can use the transactional portal to render a clerical error reopening or to request an appeal. And these self-service tools, that being our portal, will offer the most efficiencies. Our portal user manual provides illustrations and step-by-step instructions on how to use this tool. So I highly recommend you take a look at that if you're seeking advice on how to use any of the functionalities in the secure transactional portal. And you do log into that portal from any of our website web pages. So next, I do want to talk about whether you need to correct or appeal the MAC's decision to pay or deny a claim. I talked a bit earlier about that clerical error reopening, or CER process, and I told you I'd share more information. That information is here on this slide, and this is that process to correct human or mechanical errors. Clerical errors or minor errors are limited to errors in form and content. Omissions do not, some of the omissions include failure to bill for certain items or services. And examples of acceptable clerical error submissions are mathematical or computational mistakes, maybe transposed procedure code, or even transposed diagnosis code, inaccurate data entry. Perhaps there was misapplication of a fee schedule, or maybe even a computer error. All of these are examples of acceptable clerical error submissions. Now, examples of these and situations that can't be processed as a clerical error reopening are included on the resource that I've included here on this page. If someone asks me a question, Mary, can I render a clerical error reopening to fix this? This is where I go for that listing of what is acceptable or not acceptable to perform as a clerical error reopening. Now, your handout includes that link to our resource called How to Request a Clerical Error Reopening. You can use the portal for self-service, or you can request a clerical error reopening via telephone or fax. That's all included in that resource. And remember, the portal user manual provides instructions for this. For claim denials, most often, there are exceptions, you can request an appeal, and the purpose of the appeals process is to ensure that correct adjudication of claims. Physicians, suppliers, and beneficiaries all have the right to appeal a claim determination made by the MAC. And the MAC stands for, that acronym stands for Medicare Administrative Contractor. WPS is a MAC. The beneficiary or their representative can request an appeal on any service that's processed for them, but providers and suppliers can appeal services for which they accepted assignment. And there's one more exception I'll talk about in a minute. For unassigned claims, providers and suppliers can act as the beneficiary's representative, but the beneficiary needs to sign an authorization statement. It's a form CMS 1696. It's called Appointment of Representative in order to do that. In addition, providers and suppliers can also request a redetermination on an unassigned claim if Medicare denied that service as not reasonable and necessary, or if the provider or supplier billed in excess of the limiting charge. And in that case, the provider or supplier must refund any fees collected from the beneficiary. The first level of appeal is the redetermination. It is the only level of appeal rendered by the MAC. There's 5 levels of appeals as shown here on this slide, but remember, only the first one, called the redetermination, is done by the MAC. So time frames appeal to each level of appeal, all 5 levels. In addition to the time frame for the provider to submit their request for an appeal, there are also time limits that contractors have or entities have to complete those appeals. I mentioned to you the first level of appeal is the redetermination. Timeframes apply. There is also a minimum amount in controversy. Sometimes you'll see the acronym AIC used, stands for a minimum or amount in controversy. And there's a minimum amount that applies only to levels 3 and 5, those appeal levels, but you can combine like denials or similar denials on more than one claim in order to reach that amount in controversy. Here are some resources that I've included for you. The first one is a WPSGHA resource on our website, How to Appeal a Claim Determination. Very helpful. And then I've included one of my personal favorites, a resource for appeals, and that's a CMS product. It's called the Fee for Service, or FFS, Appeals Process Flowchart. And I really like this flow chart because I can quickly look at it and respond to questions about, what's the time frame for a level 3 and is there a minimum amount of in controversy and so on and so forth. So this is a flow chart that CMS prepares and publishes on their website. They do update it annually. So remember, if you're in the beginning of a new year, you want to make certain you take a look at the date on the bottom of that flow chart in order to make certain that you have the latest and greatest information from CMS. But it's a really, really nice tool. I think you'll agree. So in my ad for this webinar, when I explained to providers who were interested in registering for this webinar what I was going to cover, I told you that I was going to talk today about common rejections and denials for Specialty 01 or general practice providers. So the next portion of my presentation, my prepared remarks, includes discussion of the data that I used to provide the most common rejections and denials for Specialty 01. The data that I am sharing today is only Specialty 01 submitted claims for Jurisdiction 5 and Jurisdiction 8. Those are MAC jurisdictions. This means the states of Iowa, Kansas, Missouri, and Nebraska. Those are J5 states or Jurisdiction 5 states. And Indiana and Michigan collectively. Those are our Jurisdiction 8 or J8 states. Now, we have a tool that we call the data dashboard or dashboard for short, and it's a tool that members of our insight department, that's the name of the department, but they're data informatics, if you will, they created this tool specifically for provider outreach and education, or what we call PO, to use to drill down specific information or pull information. And this dashboard allows us in just a matter of seconds, folks, to drill down by a specific state or states, even counties. But I pulled data for our entire jurisdiction. So 6 states: Iowa, Kansas, Missouri, Nebraska, Indiana, Michigan. For those of you that may be wondering what Specialty 01 is, it is a 2-digit code assigned to a WPS provider when he or she enrolls. It's a self-designated specialty, which means that during enrollment, we ask the provider, what is your primary specialty? We do collect secondary or tertiary specialty information, but only that primary specialty is used during claims processing. It's that primary specialty, and it is designated. Now, what happens if a provider changes specialties? You need to let our provider enrollment folks know so they can update your file. That specialty code is used during claim processing in many of the edits. Some of the edits and the audits are performed will be based on that specialty. So there are some situations where a provider is going to request an appeal, and they will stipulate that secondary specialty in order for Medicare to payment, because the computer logic used during claim processing can only look at that primary specialty. So sometimes there are situations where Medicare may be able to consider a service for reimbursement, but we need to know that secondary specialty. I pulled data for claim submission dates September 1 of 2023 through February 29 of 2024. The data was last refreshed on March 13 of 2024. So any claims submitted for this date range after March 13 are not included in the data that I'm going to share with you now. What the Insight team staff does for us in that dashboard that we use is each month they go out to the dashboard, they add a new month, and they take away the oldest month. So they do tell us when they refresh that data. This data from September 1 through February 29th was last refreshed on March 13. So here then are the common rejections by reason. Why was the claim rejected? And remember, rejected means unprocessable. We didn't process it. You need to fix it. You need to resubmit it. The number one common rejection in our jurisdictions for that time period I just shared with you is that the claim lacks information needed for adjudication. So for a situation like this, you might want to take a look at that claim, make certain all of the required information is indeed on that claim. So that's what you're going to need to do. You can find that in the CMS 1500 claim form instructions or the crosswalk that crosswalks a paper claim to an electronic claim. Next common reason that I've listed here, 222. You'll notice those numbers off to the right. That means how many rejections we had for that data that I pulled within that time period. 220 claims rejected because the rendering physician number on that claim was invalid or it was missing altogether. Okay, so the system is going to um, return that claim or reject that claim. It's unprocessable. You cannot request an appeal. You have to fix it and resubmit it. So for this situation, you take a look at that rendering physician number. You know, maybe it was transposed when it was keyed. Maybe the wrong physician number is using, or one that is for a physician that's no longer valid. It's invalid. It's missing. Another common rejection reason is invalid or missing modifier. We have excuse me, we have on our website, if you look to the claims section of our website, you'll be able to choose modifiers from the list of topics that appears when you're on that claims page. And you will be able to link to many fact sheets that we've prepared for most of the modifiers that are used by Part B providers. It might be invalid in that it's not applicable based on the service that's being billed. For example, some modifiers can only be used with an E&M code. Okay, maybe it was keyed wrong. Maybe it's missing altogether. A required modifier. 153 rejections in that time frame. The next, missing, incomplete, or invalid ordering primary identifier. Kind of similar to that second bullet there where the rendering physician number is invalid or missing. This is the ordering provider identifier is missing, invalid, incomplete. Next up is CLIA number, invalid or missing. So here is where you need to check how you keyed that CLIA number. Is it missing altogether? I will share resources with you later about CLIA so you can find more information there if this is why your claim is rejecting. Next up, this is a common rejection across the board, not just for specialty 01, but for other specialties. This claim has been forwarded to Palmetto Railroad Board, 57 claims, very similar to the claim must be submitted to Railroad Board, 35 claims. So for these folks, what's happened is the provider has submitted a claim to traditional Medicare, to WPS, GHA, the MAC, when it should have been submitted to the Railroad Board contractor. That is a company by the name of Palmetto. The difference here is there's two different reasons that are being used to report this. And the difference here is that for one, you need to resubmit the claim or you need to submit the claim to the Railroad Board, which is Palmetto. And the other one, you'll notice that we've submitted the claim for you, or we forwarded that. And the reason for that is that we have trading partner agreements with some entities where they pay Medicare so much per claim to forward information to another contractor, for example. And in this case, on this claim, there was information to tell us that there's a trading partner agreement that the claim information needs to be forwarded to Palmetto, the Railroad Retirement Board. How do you tell if a beneficiary is is a Railroad Board beneficiary? Look at their Medicare card. Right on the bottom of the Medicare card, there is a red stripe and it says Railroad Retirement Board. So that then, folks, is how you would tell. You could also tell by looking up eligibility on those tools that allow you to do so. Missing procedure modifier, very, very similar to the rejection I talked about earlier about an invalid modifier. Missing, incomplete, invalid name, strength, or dosage that pertains to a drug that was billed. If the information needed to adjudicate the claim is missing, the claim will be rejected. And then finally, lab not approved to perform services under CLIA. Each provider is responsible for letting Medicare know the services, those labs that they're approved to perform under CLIA, which is an acronym for Clinical Laboratory Improvements Act. And again, I will provide a resource for you in just a bit. So not only can we look and use this tool to identify top rejections and denials, we can by reason, we can also look by the HCPCS or CPT code. You'll see those most commonly rejected HCPCS codes for specialty 01 claims submitted during that time period for our jurisdiction. Um, Subsequent AWV. I'll provide for you a resource where you can find information on how to build that AWV. We've done countless education sessions on the initial and subsequent AWV, and I'll provide for you those resources where you can find how to prevent those rejections or errors. The next code is pulmonary diagnostic testing. 90662 is flu shot. 99214 is the moderate E&M code. You'll see the G0444 there. That's depression screening. G0008 is the administration of the flu vax. If we don't pay for the flu vax, we're not going to pay for the administration. And then there's a couple of labs listed there, top rejections, as well as a couple of more E&M codes. So these are top rejections. And remember, we can drill this down by state, by county, and take a look at which codes are being rejected most commonly in those areas. We had some questions in one of these presentations that I did recently. How can I get this information from my provider? If you're seeking this information or you want this information, I believe that our insight team, not provider outreach and education, can pull that information, but you'll need to submit it as a Freedom of Information request. For those of you that belong to organizations or societies that invite WPS to send a speaker to your annual conferences and such, this is something that we can bring along or provide for you at your conferences if you would like, and we can work with you ahead of time to drill that data down. So let's look then. Sorry about that. I hit my mouse and my wheel that scrolled here. We talked about top rejections. We talked about the codes that are most commonly rejected. And remember, I'm going to provide resources for you in a bit, but most of these are pretty straightforward rejections, and fixing them is fairly easy to do. And remember, you can do that yourself using the clerical error reopening process. If it was a minor error or omission, a mathematical error, you know, with some exceptions, you can really just fix those yourself or resubmit them. So let's look now at those most common denials by reason code. First one is collection of fee for service during periods of managed care. And this, folks, there were 728 denials, and most of those have appeal rights. But in this case, the beneficiary is a managed care beneficiary, so it shouldn't have come to WPS GHA to begin with. That needs to be a service processed by the Medicare Advantage plan. Let's take a look at the next three most common denials by reason code for WPS claims. Look at that. Duplicate charge already paid on this claim. This is a duplicate charge of a already submitted. This is a duplicate charge of a claim that's now being processed. So it's in the processing system the same time as the claim for which the remittance was generated. So we have many claims, not just specialty 01, many claims across the board that are duplicates. And these are denials. You know, you do have the right to appeal. And most often for a duplicate, if it truly is not a duplicate, there's going to be a a need for a modifier to tell us that this is separate and distinct, or it says, more than one on the same day by the same provider. So take a look at your modifiers if you're receiving these, unless they are truly an outright duplicate charge. We know that some providers bill on a 30-day basis, and if they don't get payment for their claim in 30 days, they're just going to submit another claim. And that's really considered abusive by Medicare. And it really costs both the provider and the trust fund monies. It's costing you money to submit that duplicate. It's costing Medicare money to process a second claim. So we do want to avoid those. We have some good resources. I'll share them with you in a minute to avoid those duplicate denials. The next one is very popular, not just for your specialty, this specialty that I'm talking about today, right now, but for other providers. The time limit for filing your claim has expired. And here, folks, is that exception I talked about. You do not have an appeal right in that situation. So you don't need to spend time or money requesting an appeal. It's not going to be covered, but there is a process set up where you can request that Medicare waive that timely filing limit, and I'm going to show you that when I cover those resources. So time limit for filing has expired. You have 1 year from the date of service to submit your claim. More common denials. This supplier or provider is not eligible to receive payment. There you're going to want to check with provider enrollment. Why is your physician not eligible to receive payment? Next one, these services are denied because the patient is in a hospice. Again, another very, very popular denial. Check eligibility for your patient and make sure you're submitting to the correct provider. Claim must be submitted to EGHP, and this is exactly how it prints out on the remittance notice. EGHP is Employer Group Health Plan. So this, folks, is a Medicare secondary payer issue. So we have all kinds of resources on our website. We have YouTube videos that talk about secondary payer claims. Next one, separate payment may not be made for this service or for these services. Do not bill the patient. In other words, this service is bundled. And what we're talking about here, folks, are those procedure to procedure edits, part of the National Correct Coding Initiative. These are edits that CMS has put into place so that services that should not be separately paid on the same day for the same patient by the same provider during the same encounter are not paid. Next one is also related to those National Correct Coding Initiative edits designed to prevent improper payments, is denied service or units of service are exceeded. And what we're talking about here, folks, are those medically unlikely edits. Here then are the most commonly denied HCPCS code, CPT codes for specialty 01. You can see we have got a blood glucose listed there, the 82962. And remember that many labs have frequency parameters, so their denied is not medically necessary. Anything that denies due to frequency or a utilization guideline is considered a medical necessity denial. And for those, it may be appropriate to present your patient with an advance notice of non-coverage. And you need to do that, of course, before the service is provided. You need to make certain it's all filled out correctly. If it's not, it's really not valid. There's E&M codes listed here also. Again, there's that depression screening showing up, G0444. We're encouraging our provider community, those eligible providers, to render these depression screening. We had this innovation challenge project where we were trying to increase the number of these services being offered to patients as a benefit. It's valuable not just for the beneficiary but for providers as well to render this depression screening. And of course, general practice providers are going to they're eligible to bill this, but likely what happened here is it may have been submitted more than once a year. Okay. So it could have been a frequency denial. It is a screening. It's covered at 100%. There's no copay, but it's only covered once a year. Okay, the G0439 is the subsequent AWV. Again, we have a lot of great materials published about the annual wellness visits, both initial and subsequent. There's an A1C CPT code. Look at that venipuncture code making its show here as denied services. If Medicare denies a lab service on your claim, they should also deny the venipuncture for that lab service unless that venipuncture is being rendered for another lab that's payable on that same day, that blood specimen that is. But if the lab's not covered, the venipuncture is not covered. Nerve function testing is making the list again. What I would do here is check to see if there is any policy perhaps that provides those coverage and limitations of coverage. Perhaps it might be a CPT code that, or excuse me, a diagnosis code that's not allowed for a particular CPT code. And I'm just guessing here, folks. It is related, if it's related to policy, that's the type of thing you need to look for. Administration injection 96372. Similar to a lab where we don't pay the venipuncture for a non-covered lab, we do not pay the administration of a drug or an injection that's not covered by Medicare. And then there is the 99308, which is a subsequent skilled nursing facility visit. Those services do have frequency parameters, so it could be quite likely that this denial is due to frequency, and you'll need to look to your remittance advice and to the tools that I'm going to share with you in just a minute to determine why things are denying or why they're rejecting. Here's those further breakdowns that I was telling you about that we can do in the data poll, just informational for you. You'll see the last bullet there is trending. Here's what I mean by that. A good example, there's a denial code. It's an internal code, but nevertheless, there's a denial code. Here's the one I picked to show as an example. The code description or the denial reads, charges incurred during an incarcerated period. This particular, and again, I hit enter and this data comes back, boom, just in seconds. Sometimes I don't even see the data change, it just loads. Gives us the claim count during the current 3 months, prior 3 months, shows us the difference in claims, it gives us the percentage, and then it shows us a visual. It's a green arrow or a red arrow that goes up or a green arrow that goes down. And what we use this trending for is to track and view the trending for denials and rejections, because we can pull this for, this is a denials example, but we can also pull it for rejections. This is great stuff, if you will, for people like Aline and me. We can look at this information and say, you know what, I need to write a news item on this so that people can avoid these rejections or denials in the future. I need to tell providers how to fix this rejection or how to appeal this claim, or just completely avoid it altogether. So this trending helps us identify education needs. Here are some of the tools and resources to avoid these common rejections and denials. This, you might recall, is really part of that third bullet on that agenda slide, or when I advertised, I told you I was going to talk about the resources. Here are requirements for Medicare claims as it pertains to the claim form itself. Some items are missing or invalid. This is the data set, and this chapter 26, there's a link provided for you, links you to completing and processing of the CMS 1500 data set. That is claim form instructions. And you might say, well, I don't submit on paper anymore. But our EDI department staff has created the CMS 1500 to ANSI 837 5010 crosswalk. And let me show you what that looks like. It's a great tool that I do like to share with providers. I'm pulling a window open for you here in just a second. If I can get my screen to go, I'll make it bigger so you can see. If you are on the WPS website, this is our homepage. And right here is EDI under quick links on the right hand side. If I open EDI, this takes the user to the electronic data interchange website for all WPS providers. And if you scroll to the bottom, you can choose from Medicare, TRICARE, or our commercial insurance. And of course, I am with Medicare and represent the MAC jurisdictions. So I'm going to choose Medicare EDI. And right here is that crosswalk. But before I pull it open, I do want to show you or mention to you that this is where you find those companion guides I talked about the 999 and the 276 and 277 reports. This is where you can click to get to them. I provided links for you though in your handout materials, but let me show you that crosswalk. This is that crosswalk from the paper claim form to the electronic claim form. Hopefully it will open quickly here because I do have more information to share and hope to have some time for some questions at the end. So this is a really nice tool that a lot of providers don't know about or never see. If you've ever looked at a paper claim, you'll notice item number 1, item number 2, number 3, number 28, number 29, number 24J. This mimics or represents the item number on a paper claim. Item number 1 is the type of insurance, and here is where you put it in the version 5010 and the loop. It is a claim filing indicator code, and this R in the status code column, if you can read it at the bottom of the page here, is any data element that is needed in order to process a claim. That means it's required, folks. If there's an R there, that means you have to have something in that item number or the electronic equivalent. Remember, I talked to you, claim lacks information for adjudication. This is the kind of information you're going to look at to determine what's missing, what is it lacking. Is it required or is it situational? Look here under this item, item 4, see the S's? This says that this is situational, and then it tells you the requirements for the version 5010. Item number 19 is one that I want to show you. It's used often, kind of a fill in the blank because this information has no place else to go. It's additional claim information. Some policies say you need to put this in item 19 or the electronic equivalent, and that's this part right here, folks. I'm trying to highlight it. There's the electronic equivalent. It's situational. You don't need it for every claim, but if this information over in the far right column applies, if you're using an NOC code for a drug, for example, you have to pay attention to this, and you have to determine then what needs to go in item 19. Here's some information for global surgery. Some of you might be billing global surgery. I'm doing a webinar on Thursday for global surgery. This is where you put the assumed care date and the relinquished care date. So some great information. All right, that is claim form. Next, what I've done is included how to correct a rejected claim. This is going to tell you listed by remark codes. Remember I mentioned the MA130, for example. Actually, that's a denied claim, but a rejected claim. This is if you click on this link, it's going to open a resource on our website that tells you how to correct a rejected claim. Similarly, these are common. Well, I am so sorry. I'm getting here a little scroll happy here. These are common claim denials, and when you look at our website, we list the denials by reason and remark codes. So we have reason and remark codes for bundling. We have reason and remark codes for duplicates, global surgery, provider number denials. So as you're looking at the claim details on your remittance notice or in our transactional portal, you are going to recognize this is a bundling denial. I can go here to learn how to fix it, how to correct it, what I need to send when I request that appeal because my claim was denied or claim line. Here are more resources. I talked to you earlier about denials because patients in a hospice. So here's your resource, folks. MSP questions and answers will help you avoid those denials specific to MSP. We have a lot of great videos, resources. These Q&As are awesome. That's why I'm giving them to you now. Live events webpage is going to show you what we have coming up. Encore presentations are those recordings. Here's where you can look up our LCDs and articles on our website. You can put a word or a code and search to see if we have a local coverage determination or companion article for that item or service. But remember, the search is on the title of the LCD or article lookup. You might care to take a look at CMS's Medicare coverage database to see if there's LCD or articles, because I believe that looks within the document itself versus just in the title. Here is a link to our YouTube channel. I told you earlier, I'm going to share with you where you can find or where you can use a link to access more education to avoid these rejections and denials, how to fix them and to fix them. The YouTube channel actually has, I think, 46 different playlists And basically what we're doing there is we're if there's 8 different uh, YouTube videos on MSP, it's going to be under the MSP um, list of YouTube videos, the playlist that is. So we kind of bundle them by topic. Provider enrollment guides and resources. Some of your rejection says, we're not going to pay for this because this provider wasn't eligible. This is where you need to go to get the information, to know what you need to do. Pick up the phone, call customer service. You'll be, channeled to someone in provider enrollment to help you. MSP fact sheets are available. Here is that information on timely filing of claims. Um, Actually, let me get it over there for you. I told you this is not you can't request an appeal for a claim that was denied for timely filing, but this timely filing of claims resource on our website explains it a little bit. It tells you that these claims don't have appeal rights, and it tells you what you need to do in order to file a waiver to extend the timely filing limit. Providers must meet qualifications for what CMS calls good cause. And this is the information, 1, 2, 3, what you need to submit to the claims manager. It says here you're going to send it to the claims manager to request that waiver. And then down here it provides the addresses for you. I pulled this the J8 website open, or part of our website. That's why you see only Indiana and Michigan. But if you switch to J5 by clicking up here in this bar, you'll find J5 information. I don't know if you knew you could flip back and forth that way easily. All right. So these are, let me go back here. I think I got these. Oh, here's that information I told you I would provide that pertains to CLIA, those Clinical Laboratory Improvement Act covered procedures. Some of the most common rejections or denials, both actually pertain to CLIA. So this is where you can find everything you need to submit that claim properly. Here is CMS website resources. I talked to you earlier about looking for those local coverage determinations or doing a search on our website. This is where you can find the MCD, the database on the CMS website. It is searchable, so you can plug in a CPT code or HCPCS code. Here is how to use the Medicare coverage database. Kind of goes with that first bullet there and the first sub-bullet. It tells you how to use that tool. I know I did a webinar a while back, so that particular webinar is actually one of those recordings on our YouTube channel. Here is information that pertains to the Beneficiary Notice Initiative. Anything that you believe there's a likelihood Medicare is going to deny due to medical necessity, and remember folks, that includes frequency. You can read up about presenting your patient with that BNI, what you need to fill out, what you need to include in there. You need to be, very descriptive of why you believe that that Medicare may deny that service. One of those, the trending example I used had to do with the denial of claims for incarcerated Medicare beneficiaries, and it went up in the 3-month period, the one we looked at. This is where you can find an informative resource on our website that talks about these claims and when we can pay and when we can't pay. And finally, here is National Correct Coding Initiative resources for you. I've got links to the procedure to procedure edits. Those are for bundling, and medically unlikely edits. And that pertains to those claims that are denied due to excessive units billed on the same day. Okay. IVR, this is a tool where you can look up eligibility, claim status, and denials. You can use voice or telephone keypad. It is available most of the time. There is a little limited functionality outside of normal business hours. To find instructions, check out the IVR operating guide. This is a link to where it's found on our website. Similarly, you can use the transactional portal to check eligibility, claim status, claim details, claim actions. The one great thing about this tool, folks, for those of you that have never used it or maybe those that have, that haven't noticed this, when you were looking up claim details, and remember, instructions, illustrations are all included in our portal user manual. When you're looking up claim details, you can look at a claim line by line. And if you have a claim line that denied, there's a more info. I believe it's blue, at least it's blue right now. That could change. We are revising that tool for you. Should be coming out early summer. Um, there is a more info button you can click on, and that's going to give you more details about why that claim line denied. Let me give you an example. If the claim line denied based on diagnosis, we don't pay this diagnosis for this service, that's going to be related to a policy. Policies equal edits. Policies explain what is medically necessary. That more info button, when you click on it, is going to give you information about that denial, and it will provide you with an opportunity to click and open that policy up right then and there. You don't have to go elsewhere. You can open it right from that button or that list of additional information that appears. So good stuff. Just a reminder for all of you, self-service tools like um, the SIR process, using the portal or the IVR, look up these rejections and denials and find more information on them, really is the fastest way for you to take corrective action. If you want to use the clerical error reopening process to fix something, you can do that yourself. You don't have to call someone in customer service and have them do only so many per day. Here is some great, or I provided for you other resources in the previous slides. We have just a couple of minutes, and I apologize. There's a lot of information in this particular webinar. I don't have a lot of time for questions, but we can take a couple here. Aline, are there questions?
Mary, yeah, we did get a couple questions. One of them comes from Carmen, and she says, if we have a claim with 4 lines, but only 1 line denied, do we resubmit the entire claim or just the corrected line?
That's a great question and a very common question, and we do have resources that are published that speak to that. So what I'm going to do, because there's a lot of ifs or ands, I would like to follow up with an answer to you, and I will do it still today, to that question regarding the MUEs and correct submissions of them. So I will follow up with that and your resources following this event. We're just limited in time now, and it's just too long to get into. But how about another question? Real quick.
Sure. This one's from Jenna, and this one says, labs that we've submitted recently have started to deny, saying the lab is not approved to perform, such as urinalysis, when we've been paid for them in the past, even in 2024. So the coding is current. So she asks, is this denial in error?
I can't tell you if the denial is in error until I look at that claim. And that is exactly why, if it's specific, like a claim specific or provider specific question, it really does have to go to customer service, because they can look at the system. They can look at the claim, whereas provider outreach and education, Aline and I, we can't do that. We don't have the tools to do that. CMS says we have to do widespread education, so we don't do the one-on-one. But I will tell you that I'm not aware of any problems that have been identified, and you can find if there's a system error and such, you can actually go out to our homepage, and I'm not going to lie to you, I'm going to have to look at it here, because these types of errors that are occurring, all systems functional here, so systems good. If there is a widespread problem, we're going to put that out here on our web page here. Claims processing alert is what I'm looking for. So you can click on go here to see if there's any alerts. And this isn't opening quickly for me, so I apologize for that. But here on our front page are those MCS alerts for identified problems. I know that Part A, Aline, also has something similar where you can look to see if there's been issues identified and if they've been fixed. But of course, today we're talking about Part B. So that will provide you with that. So back to your question, I don't know if there's an identified problem. I haven't heard about it, but I would call customer service and be prepared to give them a couple of ICNs so that they can look up and see what's happening to that specific claim. All right. I apologize for going over. I've got 11:04. I do want to tell you that our greatest compliment is when our provider community and their staff recommends our education to others. And we'd ask that you please consider doing so. This helps us reach the greater provider community and it helps us reach our goals to make certain we are giving current needed information to all of those in our MAC jurisdiction. So on behalf of myself and to my friend Aline, who's helping me out today, we do want to thank you for your participation. All of us in provider outreach and education look forward to those survey comments. Please send them. Please complete that survey. And we really do hope to have you join us for future events. You may now disconnect. Thanks, everyone. Have a great afternoon.